Good afternoon, everyone, and welcome to our Practical Communication Tools and Tips for People with an Intellectual Disability webinar. My name is Nicole Radford, one of the project managers for the Supporting People with an Intellectual Disability to Access Health SPIDER project, and I'll be your facilitator for this webinar. Alongside me is Kerry Robinson, also project manager of the SPIDER project, and Jade, Workforce Development Officer at Western Victoria Primary Health Network. I'd like to begin by acknowledging the traditional owners and custodians of the lands and waterways from which we are all zooming in from today. We recognise their diversity, resilience, and the ongoing place that First Peoples hold in our communities. We pay our respects to the elders, both past and present, and I wish to extend that respect to any First Nations people connecting in today. We commit to working together in a spirit of mutual understanding, respect, and reconciliation. We support self-determination for First Nations peoples and organisations, and will work together on closing the gap. And just a little bit of housekeeping. The majority of our webinar events are recorded and freely available on our PHN Learn YouTube channel. Jade will put the link to access our recorded webinar events into the chat. I have our upcoming events on the screen, and you can register for our events on the website. Jade will put a link into the chat for you. A special mention for our upcoming Primary Care Conference. This is a hybrid conference where you can attend from Geelong, Horsham, Warrnambool, or Ballarat venues, or dial in remotely. The theme for 2023 is Toddler to Teen Health, and we look forward to seeing you there. Please make a note of the Western Victoria Primary Health Network health pathways relating to this topic that's shown on the screen at the moment. If you have entered this webinar not displaying your accurate first and last name, please type your full name into the chat box. Only administration will be able to see this, and this will ensure that we can issue your certificate of attendance. For this afternoon's webinar, all participants will remain on mute. If you have any questions, please type them into the Q&A box, and I will ask them on your behalf to the presenters during the Q&A time. There is a link in the chat box to complete the survey after the webinar, and we will show this slide again at the end of the presentation. This afternoon, you will hear presentations from Leah Dark and Marie Island from Scope Australia, and Kathy Basterfield from Access Easy English. I'll now hand over to Kathy to commence the presentations. Thanks very much, Kathy.
Thanks, Nicole. I'll just get myself set up and share my screen. Hi everyone, and thank you very much from the Western Victorian Primary Healthcare Network for this invitation to talk to you all. My name is Kathy Basterfield. I'm a speech pathologist, and it sounds a bit scary to say that I've actually now got 35 years experience working with people with multiple and complex needs, and more specifically with people with intellectual disabilities. However, over the last 18 years, I've actually been writing and developing what we call Easy English. And my business actually employs 8 staff these days, and we write content for a range of different people, but particularly looking for people who do have difficulties with their reading and may also have an intellectual disability. My website is there for you to see. Before I get going, I'd just also like to acknowledge the traditional owners of the lands on which we gather and are coming from, both past, present and emerging. I'm coming to you from the lands of the the Bunurong people of the Kulin Nation, which is actually southeast Melbourne. So about where I'm coming from and what we actually do. So we're actually a specialist service. We're Australian based, but we actually do work internationally. We've been doing some work in South Korea, we've been doing some work in Singapore, and we're reaching out to the US, the UK, and South America. And the vision that I have for my business is that it's a society that actually includes people with low literacy, which we know as people with lots of with intellectual disability. And to have as part of that quality, meaningful, easy English that meets the needs of the intended reader. And some of you may have seen some content out there. And what I want to really emphasize is the importance of making sure that we have quality, well-developed content. Because just like everyone else, that if it's something that actually doesn't look good, that doesn't actually do what you want it to do, people are just going to throw it away. So just where have we come from? So I've been running this business now for 10 years. And last year we were privileged to be acknowledged for some of the work that we've been doing in this space. So I wrote the original guidelines that we used for Easy English back in the mid-2000s. And this is a culmination of some of that work and the work that I've been doing for the last 10 years. And so we've been acknowledged last year for the work that we did in Victoria here, particularly on creating a lot of content in the health literacy space around COVID when we had all our lockdowns. We've also been acknowledged for being the most outstanding communicator in the NDIS sector. And last year I had the opportunity to go to the UK where we were awarded an international award for being the most outstanding communicator in the disability sector, particularly around the work that we do in Easy English. And I've just come back from Vienna, where I've been able to talk to lots of other people about access and inclusion. And like with everything to do with communication, it seems to be the little bit of the forgotten part of access. And that's why it's really important that we do have these conversations and start to think about what does this look like for people who have, in particular, low literacy. So I want to start off with the Universal Declaration of Human Rights, which is over 70 years old, and also the UN Convention on the Rights of Persons with a Disability. And we're aware that Article 26 is something that has been particularly focused on in a lot of these webinars and this series of content that we've been doing. But there's a few others that both myself and Leah and Marie would also like to draw your attention to. So hopefully we won't be repeating ourselves through this hour. So the first one, so there's a few here that we need to think about. And there's the first one you need to go back and have a look at is the definition of communication. Number 9 is accessibility. Number 12 is equal recognition before the law. And number 21, saying what you want and access to information. I'd also go back and looking at the pandemic and saying that there's also number 11 around emergencies. And what does it say about that around people's needs and people's rights? So accessibility. So accessibility, we always seem to think about, toilets and bathrooms and ramps, which are all very, very, very important. And I'm sure Marie would say that to you as well. However, the bit that continually gets overlooked is the part around communication. And when you go and have a bit of a look into it at more depth, one of the things you start to see is things like plan together. And the work that we do does involve the people who actually require it. We listen to what they actually need. It also says talk to people with disability about how they find information and where they get it. And I have to say, in the 18 years that I've actually been writing and creating Easy English, there is not one person with low literacy who's ever said to me, put it on a website. So we need to rethink that. We need to go back and re-establish, well, where do we put information when people don't want it or don't see an internet and don't use the internet? It also says write in everyday words, use sign language and use sign interpreters. And they must be easy to read. And you must also have access to Braille. So how much are we actually doing? Because Australia is a signatory to this. So what are we doing? How are we measuring these things? Article 12, or in what we write in Easy English, Article 21 or Part 21, you have the right to information and the right to speak up, to say what you think. It's very difficult to say what you think if you actually don't have any information that you know about so that you can make those decisions and choices. And these are just some of the different ways that you have a right to access information. And in particular, we're going to focus in on the one that talks about easy words and pictures. But this is not the only way that people need access to information. Different people have different needs. You get it at the same time as other people. There is no point in waiting a month or 6 weeks after a medical appointment or information that you need, and 6 weeks later you finally get some facts about the decision that you needed to have made 4, 5, 6 weeks ago. You have the right to use other ways to talk. And then we need to think about all these other means of communication of TVs and computers. And you need to be able to access these too. And you may have different needs. And it's us as services that need to make sure that those changes are there. So it's not pushing it back onto the consumer who actually needs to make the change. They need to, well, hopefully they don't need to tell us, but they need to have the opportunity to access in the way that they need. So where do we go to from here? What we do need to start looking at is the 2021 Australian Commission on Safety and Quality in Healthcare. This is something that has been driven and created by the Australian government, and it's through their safety and quality healthcare framework. And what they talk about in healthcare and in health literacy is that there's two parts that we need to think about. First of all, there's the environment in which we engage and the individual's health literacy. Mostly when people think about health literacy, they think about just the person's health literacy. But in fact, it's far more than that. It's the environment in which you engage, plus what you bring to the table as your own individual skills. However, when we look more broadly and we look internationally, there's actually a third element to this. And it's acknowledging that health systems are complex and that we need to be looking at, well, what do we need to change? What do we need to look at in terms of the policies, the practice, and the structural needs that people have? And what can we do to make sure that our health services are actually person-centred? And this is actually a working paper from the OECD that you can go and read up a whole lot more. And it's actually the combined interaction of the policies and practice with the structure, the environment in which the health literacy occurs, and then your individual skills and abilities. So it's not one thing, it's three. And you'll see that although I've got three circles interacting, they're not really engaging with each other. And this is what usually happens in our health world, is that what we actually can do on an individual level is not interacting well with what the environment needs to step up and do, and also structurally and with policy. So what are the sorts of things we need to think about in the health literacy environment? Well, there's a number of things that every clinician needs to be thinking about, and thinking about it from what you bring to it. So first of all, we need to be thinking about your relationship with the consumer. And then if they have supports around them that they bring into that health environment, what the relationship is with the family, and where supported decision-making may sit in that space versus independent decision-making. What's the relationship with the support staff, particularly for those clients who live in supported accommodation? And is there a primary person who knows more about this person? Is that the right person to be there? And then there's the other allied health staff and other medical staff. We need to bring to this conversation in our environment cultural awareness. And it's not just thinking about First Nations people. It's not just thinking about people of English as a second language. People belong to different cultural groups. And so we need to be really cognizant and be aware of what that brings to your conversations. You might identify as being part of the disability community, and what cultural things do you bring to that? What about those who belong to the LGBTIQ+ community? How does that affect the environment in which you engage in your medical conversations? There's also something else that you as the practitioner needs to be thinking about. One of the very big things need to be thinking about is the choice of words that we use. It's very easy to trip over the words that we use with our colleagues and use them constantly, lots of those big words. However, we can't assume that anyone else knows them. And to be having a conversation with any health practitioner should never be a test of what words the client knows. We need to be engaging and using the words of our listener, of our consumer. We need to think about the length of sentences. What do we expect this person knows? What general knowledge do they bring to the conversation? And from my point of view, that people with low literacy have there's a very high correlation between a low general knowledge, low health knowledge, and low literacy. And what are our expectations around time? We're always time pressure, there's always time poor. But in fact, we need to be thinking much more about where that pressure is coming from and what does this consumer need. Need to also be looking at your knowledge and assumptions about how this person tells you things, how they get their message across. Do they use speech? Do they point to pictures? Do they point to objects? Can they point to known words? Can they spell? Do they use signing? Do they use different languages? Perhaps they use natural gesture and body language. Maybe they use movement around the room, picking things up and putting things down. Are you certain that you actually know how that person gets their message across? And what are some of the things you need to bring in that space? And I know Marie and Leah are going to address some of that in the work that they do in particular. But there's another part of it too. So that's about how someone expresses themselves. What else comes into this environment is your knowledge and assumption of what someone understands and how they understand. And do you need to be using keyword sign and natural gesture? It's a tool that is very valuable in your toolkit to have. You may not need it with every person that comes in the door, but intellectual disability means that we have difficulty understanding and learning new things. We have more difficulties when we're in an unfamiliar space. Maybe keyword sign and natural gesture is going to be the link to help that person understand. Pointing to pictures or objects. Actually talking about what you're doing, is that going to help the person? Do you know that? Modeling it on your body, maybe then trying it on their body. Doing small steps. And that thing around time again, slowing down. And how can we relate it to their life experience? And so we have this enormous piece of work where we talk about the health literacy environment. And as speech pathologist, we need to ask you, is there a role here for speech pathologists in assisting the rest of the health environment, the rest of the health practitioners, to become more aware of what needs to happen in the environment to improve the interaction that happens with people? And so we have the health literacy environment. The other piece we have here is the person's individual health literacy. And I wonder how many of you recognise these sorts of photos and shots of the wall of brochures that sit on the clinical wall, either in the doctors or the specialists or down at the community health service. And all these brochures in trifold. How many then get picked up and taken away? And this is what they start to look like. And the one down here on the right, just lots and lots of language on them. Different colours, so they must mean different things, but basically they look the same. There might be a picture on them, but they're very, very small. And when you open up, they're full of words. Or you get this. And this is to help you become more person-centred, more individualised, being able to direct your own healthcare. What assumptions are being made about your skills and abilities if this is the sort of information we're being handed as patients and consumers of our own health needs? Fact sheets, preventative health information, anything and everything that you can imagine we need to learn is usually presented in this sort of style. How many people can actually engage with this information? And so there is some data out there. And I was actually at a presentation being done by Professor Risha Osborne from Australia at the WHO back in December. And our Assistant Health Minister was part of the introduction to that. And she actually said, and this is accurate data, of course, only 2 in 5 people can actually manage their own health information with their health literacy skills. So 60% of people do not have the literacy to manage a range of day-to-day health literacy information. So we ask ourselves, how useful is this information? One of the really interesting things when you look at how people are actually engaging in content and you're asking them to participate is Professor Osborne has actually spoken about how if we only use surveys in standard language and standard layout, we're only talking to the people who can manage and read that. You're not talking to the people who actually need more assistance. So let's just have a quick look at that literacy data. Now, normally I have a graph, but we don't have time to go through it. So this is our representation of what happens with our reading skills. So all those blank spaces, now it's not a hard and fast rule line, depending on the topic, that may vary a little bit, but basically 44% of adults in Australia do not have the literacy to manage a range of day-to-day reading tasks. That does not include rural and remote Aboriginal people. It also does not include anyone in an institution, which includes people who live in group homes. When we think about numerical ideas like things like over and under and tomorrow and yesterday, there's fewer of us that can manage those day-to-day numerical tasks. Health literacy has lots of numerical ideas in it. And here we've got only 2 in 5 people can read and interpret day-to-day health information. So maintaining and using content in the way that we have been doing does not meet the needs, not only of people with intellectual disabilities, but also many more people in our general community. So if I take you back to that idea of universal design, that if you actually think about what do most people need, it's actually something that is going to benefit more and more people. Because these are also people who do not have the literacy to manage a range of day-to-day reading tasks. This is actually some photos from a program from the SBS 18 months ago now called Lost for Words. And none of these people have the literacy to manage a range of day-to-day reading tasks, let alone health information. So it's a really hidden disability. It's a hidden problem that none of us are addressing in the right way. And I want to just go back to that idea that access to information to participate in your own health journey or any journey is not about being a reading test. I don't want to know how many big words you know or how many complex phrases you know. It's about what are the skills that we actually have that we can bring to the table today. And the more information you give someone, the higher the thinking that needs to go on, that makes it much, much harder for people. And this is where we've got to in writing our easy English. And what I just want to finish off with are some examples. Now, there are consumer engagement with all these projects, but I don't have time to go through them. But these are just some examples that you can go and find on the website. You can download them and use them for free. So this is like a survey. Okay, this is from Australian Women Against Violence Alliance. The Australian Women Against Violence Alliance. And this is what a survey might look like, you know, collecting information from people who do not normally have the skills to engage. You can see there's very few words and there's only 4 images on a page. You need to be able to talk to someone. And here's what we created for their content so that people would actually engage better and find it. One of the things they've actually got here is an app called Sunny. Sunny is a domestic violence tool that people can actually go onto with very simple words. It's not in easy English, but it's got very simple words. The people who actually created it had been to our training, but we were not involved in creating it. As part of doing it, we usually find that there's content that is assumed knowledge. And so in creating this survey, we actually created 2 books that you can go and use and download. What is violence? And here's just some examples from book 1 about the type of content that sits there. So this is the section on about how a person makes you feel. And then at the end of every section, we've got this highlighted point. There's the actual word that maybe the clinician might use, or they might hear it when they go to the police, but we've explained all of it before we've got there. And if they don't remember that phrase, that's okay, but it's never okay to do these things. Brochures. Brochures are incredibly important. Brochures tend to be an evolution where everything gets put into it. Brochures need to be in bifold when we do them in easy English, because then it's just a simple book. So this is Syndromes Without a Name, and they had a set of 4 created. You can go to their website, you can download them. They've also got a toggle on their website. You can get the content on their website in simple, easy English too. This is some work we did pro bono. So this is where we received the award from Victorian Business Awards. So these are just some of the things we did for COVID. So you can see when you actually get to see it on a website, it's the only way we can get it out. There's a front page, so you can see what you're looking at. And then once again, very little content, but it's actually all there. And so we created a series of different things, same sort of look, empty pages, because people with low literacy, if they see a whole lot of content, they're just going to push it away. White space for them is thinking space. And then we rolled it over and did some stuff for Special Olympics Asia Pacific on COVID-19 too. I'm going to have to wish through. More surveys that have got ethics approval. So going through the universities, it is possible to get a survey done. Disability action and inclusion plans. It's lovely to see them actually include the need to access information in it. And at that point, I'm just going to finish off and say to you that to actually develop Easy English is a skill development that you need to have some specific training to actually do it. We offer that, we offer webinars. We also have our team of staff who actually happily like writing projects of your content. So they'll take your complex content and they will simplify it so that they can, so that you can then use it with your community of users. Thanks very much for your time, and I look forward to any questions at the end. Otherwise, drop me an email. Thank you.
Thanks very much, Kathy. What an excellent presentation, and really staggering statistics that only 2 in 5 people can read and interpret the day-to-day health information. So I think that although today's session is focusing on people with an intellectual disability, I think that really highlights the importance for the whole community more broadly as well, and the importance of having easy communication.
Absolutely. And it's one of the difficulties that we find, of course, is that we don't do the data collection on this very group of people. And so how do you how do you do it, except that, you know, we've actually got the representation, we know what it's like in those communities. We've got some very broad data, but they're not included in this national data that we have. Thank you.
Thanks very much, Kathy. Really, really excellent presentation. And I'll invite any attendees to start adding questions into the Q&A box, which we'll ask at the end. And I would now like to hand over to Leah Dark and Marie Baker from Scope Australia to share their presentation. So thank you very much, Leah and Marie.
Thank you very much. I'll just get my presentation up and I'll wait for Marie to get herself ready as well.
Hi.
You're all good to go, Marie? Wonderful. Thank you so much. Well, welcome, and thank you for the opportunity to be able to speak to you today. My name is Leah Dark. I'm also a speech pathologist, not quite as many years as Kathy in experience, but a little over 20 years now. So a bit to my experience there. And I also have worked my whole clinical career with people with disability, not only intellectual disability, but other types of disability as well across the lifespan. And I've also been involved in teaching in a university setting as a lecturer. And in some research roles as well. I'll just, before we begin our presentation, also hand over to Marie. Marie, would you like to give a short introduction about yourself as well?
Hello everyone. I am Mary Ireland. I have a law degree and I work with Scope's Communication Inclusion and Resource Center as a communication assessor and trainer.
Thank you, Marie. And it's lovely to co-present this presentation today with Marie, and you'll hear from her later with a personal story to set a little bit of context about what we're going to be talking about today. But our topic is practical strategies to support communication access in health settings for people with intellectual disability. Before we begin, we also would like to acknowledge the traditional custodians of the lands on which we meet and pay our respects to their elders past, present and emerging. And we'd like to extend that respect to Aboriginal and Torres Strait Islander peoples here today. So as mentioned, Marie and I work for Scope, and Scope is one of the largest non-profit disability service providers in Australia. And we support thousands of people with complex and multiple disabilities across the lifespan, with numerous programs including therapy, accommodation services and community inclusion programs, amongst many others. Marie and I, as Marie mentioned, work for a part of Scope called the Communication Inclusion Resource Centre. And the work of CIRC, as we call it, is really about facilitating inclusive and accessible communities throughout Australia, with a particular emphasis on communication access and the needs of people with communication disability or difficulty. But that feeds into Scope's broader mission about wanting to enable each person that we support, and more broadly in the community, to live as an empowered and equal citizen. So a lot of the work that we do in CIRC and Scope more broadly is about identifying, understanding and trying to break down barriers to access and inclusion that exist in the environment, as Kathy was talking about earlier. And that environment can include both beliefs and attitudinal components, and also practical, physical, and in our case, communication barriers as well. Without going into a huge amount of detail about the Convention on the Rights of Persons with Disabilities, because Kathy has set the scene really nicely with that, we also, however, use this as a framework to think about the work that we do and what we want to share with you today. And that really is that communication is a human right. And in particular, Article 21, that freedom of expression and opinion and access to information in formats that are right for a person, is so fundamental to so many other aspects of life. So it is its own article, but actually it feeds into many of the activities that we participate in as humans in our life. So I think this is actually really interesting to see that I've been able to capture the whole article in its original wording in one slide. But when you present that in an accessible format with simpler words and images to represent that, I believe it's stretched over about 5 or 6 of Kathy's slides. So you can put the two side by side and really see what it is about to break that information down and help people to access that easily. But what we're talking about here is people with disability having the right to express themselves, freedom to give information about themselves, about their life, but also receive it through all different forms of communication. And that includes a range of different accessible formats, technologies, sign languages, Braille, as was mentioned before, a group of communication methods that we call augmentative and alternative communication, and that's a very large area of work, broader mass media, and all sorts of other accessible means of communication as well, including how we might adapt verbal communication for people with intellectual disability. The other part of the big picture frameworks that we're drawing upon today in our presentation is also about health literacy, and taking just a slightly complementary approach to Kathy's. I just wanted to present one particular model of health literacy, and that is Christine Sorensen's model. If you've looked into the area of health literacy, you will know there's a lot of models out there that talk about what it is and, you know, what's involved in it. But I particularly like this one because I think it really shows the complexity of this process and how much is involved in the process of health literacy. So as you can see from the table, it's not just about accessing information about your own health needs or your own health care. It actually spans a range of different areas of health awareness and health action, not only health care, but disease prevention as well. So understanding risk factors and activities to prevent disease and poor health, but also that health promotion and health advocacy kind of space as well. So understanding broader social determinants of health and how the environment influences one's own health and that of the people around them. And then across the top, you can see that health literacy is also not just about being able to get information in a way that is accessible. It's also about really being able to understand that information, know what it means, unpack some of the terminology and be able to relate it to one's own experience and one's own life, but then also process that information and make decisions about that information, evaluate whether it is good information for me or not good information for me. And then finally, actually use that information in applied ways related to own health. So I use this framework and I'll sort of keep coming back to it with some of the practical tips and strategies that we'd like to share because it really is about supporting people to be able to do all of these things related to health literacy, not just get the information in the first place. So in the next part of the presentation, we'd like to talk about this notion of communication access and inclusion as a way of supporting health literacy and facilitating health literacy and understanding the different health literacy skills that people with intellectual disability bring to their health interactions. So firstly, just a little bit of a definition about what do we mean by communication access and inclusion. Communication access occurs when people are respectful and responsive to individuals with communication difficulties, but also when there is use of strategies and resources to support successful communication. So awareness and understanding alone is not enough for communication access and inclusion. There is an active part to it as well, which is about changing what we do and upskilling in the strategies and resources that we use with individuals. And this is in the context that 1 in 3 Australians with a disability report that their customer needs across a whole range of different contexts, health included, are often unmet. And foundational to a lot of this unmet need is often communication breakdown. So before we go much further with that, I'd like to hand over to Marie, if you're ready there, Marie, to share a little bit of a personal story and experience of a health interaction, but also the importance of communication and communication access in that context. Thank you, Marie.
For me, communication access is knowing that people who I need to communicate or talk with have the right attitude, skills, and ability to interact with me in a positive and respectful manner. For me, communication, the right attitude is when the person can recognize, respect, and respond to the method of communication a person with communication disability is using and assume competence of the person. The skill is that the person has some knowledge of the various communication methods a person with a communication disability may use and understand what the person is saying to and interact accordingly. All this should occur in a natural and non-stressful way. I've had many experiences in my life with healthcare services. These have included doctors' clinics, healthcare clinics and hospitals. In the majority of cases, medical staff have been aware of my communication method and have accepted and adapted to it. Then there have been those experiences which have occurred through ignorance, rudeness, and can be changed with communication access education. in hindsight and without any harm being done. For example, one experience occurred when I was being threatened to be moved to another hospital for dental surgery. While they were assisting me, they were having an interesting discussion about their dates the night before. Unfortunately for me, the first item they had packed was my light writer, my communication device, so there was no way I could stop the conversation to say they were doing something the wrong way. There have been other experiences where I needed to rely on my support worker to explain my situation. Not good but fixable through education. My recent experience. Before I elaborate further, I need to say a few things. I realize my situation became an emergency, so staff had to act quickly at times. This would be one medical experience where I did feel scared and unsure whether I would make it through. Last August I moved to Williamstown. The first doctor's clinic I used closed after a few weeks. I tried a few other clinics, but they were not taking new clients. I tried a few other clinics, but they were not taking new clients. I left it for a few days. In early October, I developed a cough. I left it for a few days. Then I tried a medical center at my shopping center. The doctor quickly examined and gave me Telfast to take. My cough didn't improve. In fact, I had to sit up at night to stop coughing so I could sleep. I then decided to go back to my previous doctor in Essendon where I had lived. He examined me thoroughly and put me on antibiotics. He then gave me a referral to get my chest x-rayed. I did that straight away. The next day the clinic rang to say go straight to a hospital emergency department. It turned out I had pneumonia. I was admitted and my support worker helped me to settle in and have dinner. My sisters came to see me. I coughed a little but was feeling okay. My support worker had to leave at 9:30 p.m. I then had to get into bed, and this is when all the problems started. When I laid down, my coughing worsened. I tried to tell them this, but I was told to get into bed and lay down. I then started coughing non-stop. Within half an hour, I was put on an oxygen machine and rushed to ICU, without being told why. It was early morning and my partner rushed back from interstate. I was in a drowsy state, surrounded by medical machines and with no idea where my light writer was. My partner spoke to the head doctor explaining the effects of my disability, hoping this would be relayed to all medical staff. Now, I am just going to point out some incidents, which I can only describe as scary and to some extent disrespectful. The incidents were continually being told to lay down even though laying down made me cough more and longer, to the point where I thought I could choke. I eventually managed to get some cushions behind me so I could slightly sit up. I insisted that I sit in my wheelchair during the day. Some staff allowed this, whereas some did not. It was very confusing. On the second day, a young speech therapist came to see me to investigate reasons for my coughing. She had been asked to investigate whether I was at risk of asphyxiation. I was still tired, and she just poured a cup of water into my mouth. I use a cup with a spout which slows down the flow of liquid into my mouth. When she poured the water from an open plastic cup, of course the liquid flow was too fast into my mouth, and I started coughing uncontrollably. She then put me on a liquid diet through a drip for a week. The only liquid I could have in my mouth was flavored water on a sponge. There's one incident which will always stay in my mind as scary. It was about 1 o'clock in the morning. I was laying down trying to fall asleep but coughing. I pressed my buzzer to get some pillows to be propped up. A female staff member came in saying, "What do you want?" I managed to type pillows to sit up a bit. She said, "No, you need to lay down and sleep. If you don't do as we say, you'll die." I was stunned. I am not sure if she thought I could not understand her. Regardless, though, it was a horrible experience. The next morning, I told my support worker. I've been told they had you a nurse. They were very apologetic. I'm not sure what happened to that staff member, but I didn't see her again. I did get an apology from the head nurse. Towards the end of the second week, the antibiotics were working, and I started to feel better. The doctors started talking about moving me to the ward. So, on the day I was moved, I was told the ward was short-staffed and I would have to wait for any assistance. My day support worker finished at 4 p.m. So, I was left by myself in the bed till about 6 p.m. I managed to SMS my partner about my situation, and he said he would come after work, which he had to do. The remainder of my time in hospital ran a lot smoother, and I was taken off the liquid diet. I could order meals from the cafe downstairs. My pneumonia cleared up. The medical staff became more receptive and respectful of my communication with my light rider. I was able to go home at the end of that week. As I said at the start, I have had many experiences with healthcare services. I have heard many incidents from people with disabilities. But this one incident has left its mark on me.
Thank you, Marie. I think it's really powerful to hear stories like that and the holistic nature of people's lives. And some of the themes that I took from that is, not being listened to and how scary that can be in an unfamiliar environment when you're feeling vulnerable.
Right.
And just the importance of having a shared understanding of someone as a person and their background, not just their medical needs, but actually their whole life needs. Thank you for sharing that, Marie. And it actually segues really beautifully into the next part of our presentation, which is about how can we facilitate these accessible and inclusive health interactions. And I want to sort of introduce the fact that we're going to be thinking about what can individuals and their support networks be doing as strategies, what can happen within the interaction between a health practitioner and a person with a disability, and then what can happen in that broader picture, that community context at the level of a service, for example, a GP clinic or a hospital ward or something like that. And I'm also going to talk then about specific strategies that help with preparing for health interactions, participating in them, and then that action and going on to do something after them. So the follow-up that occurs. And as I mentioned before, all of this sits underneath that bigger picture framework of health literacy, which is about accessing, understanding, processing, and using information. So I just wanted to share some strategies that can support preparation for a health interaction. Part of Marie's story was about having to keep sharing information about her own health profile. And sometimes that information was missed, and that ended up having quite significant consequences. So using communication strategies and tools like an individualised patient profile or a health passport that can actually be prepared ahead of time and shared with relevant health professionals is really, really helpful and very important from a safety point of view as well. And the image there shows just one example of these, and this is called My Health Matters, which is developed by the Council for Intellectual Disability. I am also aware, actually, that PHN, as part of the SPIDER project, has developed a patient profile template as well. So there's quite a few out there that can serve this purpose. For many people with intellectual disability, and also particularly those who might be autistic as well, using a social script or a social story, as you might have heard them called, is a really helpful way of helping a person understand what might happen within an upcoming health appointment or health interaction. So it's really a behavioural script, and it outlines what steps are going to be happening in that interaction, what the environment might look like, and what the person might need to do or be able to do in that situation to make themselves feel comfortable. The final strategy that can be really helpful in terms of preparation as well is people taking time, so individuals taking time with their support networks to perhaps pre-program some messages ahead of time. So in Marie's case, she might actually want to pre-program her communication device with some of her concerns or questions for her health practitioner. For others, they might want to write down some questions or prepare a little bit of an introduction card to their health professional as well. And all of these things just help pave the mutual understanding and shared information about a person before they even get to their health appointment. And these are just a couple of examples there. As I mentioned, the My Health Matters, and Westmead Hospital has also developed some social scripts for children who might need to undergo some procedures. Within the health interaction, some strategies to support participation. So some of these are just general best practice communication principles. So communicating directly with the person. If they're not able to participate independently in that interaction, that's when they can, call upon the support of a support person. But I think it's best practice to always try and engage the person first and give them the dignity and respect of being the patient and the one who the communication is directed to. You can become familiar with the way a person indicates yes and no, simply by asking them, can you please show me how you will say yes? And how do you say no? And what that opens up is the opportunity to ask some yes and no questions throughout your interaction to really get at specific information as you go through. You can also become familiar with a person's communication system that they've brought along by asking them, can you show me how you use it? How would you like me to use it? What do I need to do to use your system? In your own service, it's great practice to have access to some specifically designed communication tools that suit your particular context. So some communication systems or some easy read or easy English information that you've prepared ahead of time. And in the absence of a communication tool that person brings along, there is something that you can use then to facilitate shared understanding if that person uses symbols. And general principles about presenting information clearly, one idea at a time. Often we're tempted to give information quickly in the name of efficiency, but it's not always efficient because it's not effective for lots of people trying to understand that information. Presenting actions in really concrete day-to-day language. So, for example, if you're talking to someone about how they'll take their medication, you're going to wake up, you're going to have a shower, You're going to eat some food for breakfast, then you're going to take 2 pills. So it's not take your medication at 8 o'clock every morning, which is quite abstract for a person to understand. And you're wanting to be checking for understanding as you go along. So when are you going to take your pills? And that person has the opportunity to show you what they've taken away from the messages you've shared. So some of the systems that you might be able to use, or you might see people bringing along with them, are things like this, with symbols in a bit of a grid that people can point to, but also that you could point to indicate what might be happening or what information you'd like to share. This particular series, developed by Keyword Sign Australia, actually has some keyword signs that go along with the symbols. So if a person uses a form of signing, be it Auslan or be it a keyword sign approach, you can actually learn and have access to some of those signs in context to be able to use with that person. Other systems might have more of a phrase-based approach to it, so they're whole messages, not so much single words that a person combines. And a person who is literate might come along with, for example, an alphabet board to be able to spell their messages, which is, for example, how Marie would use her device to spell out. There are a whole range of different communication systems that you might see, and they're all quite specific. I've put a few examples there. I won't go through them, but there's some links to follow up if you're interested in learning more about any of those. In terms of follow-up information, this is when I think that accessible information really becomes important. So having health reports, summaries, individualised plans, discharge summaries available in plain language, easy read, easy English, or even thinking a bit more broadly about different modalities of presenting information. So maybe an alternative to written is actually a simple audio version that the person could listen to as well and know that they've got the information correct. It might also be using strategies for helping a person implement things in their daily life. So an activity schedule with visuals, a timetable to know exactly when to take medication or something like that. Or, for example, a visual medication guide as shown there. So these are all strategies about individuals and the interactions that they have. But I want to finish with thinking about, as Kathy mentioned, the environment more broadly and communication accessibility, which is really this idea of overcoming barriers in the environment. We want anyone to be able to go out into the community, know that people will be welcoming, friendly, treat them with dignity, talk to them, give time for a message to be shared, listen to what they have to say, and be able to use alternative methods of communication. So one way of supporting this process at a business or a service or a community level is to explore the journey of communication access. And in 2011, Scope launched the Communication Access symbol. And this is a symbol that has attached to it 10 standards that need to be met in order for it to be awarded. And it's awarded at key customer service points. And when someone sees this symbol, it means that the service is communication accessible. Staff are trained, they're aware of what it means to be communication accessible, and they're skilled and knowledgeable about strategies to use. It's really that final piece in an accessibility puzzle, and we're often familiar with a lot of these symbols, and the communication access one is equally important when we're thinking about the environment. So if your service, for example, was interested in becoming communication accessible, it starts with a process of understanding needs, developing customised communication tools, training staff, completing an audit with consumer testers and assessors like Marie, and eventually giving the award, and then looking at the sustainability of that over time. And I think that's a really, really important part of, for example, what Scope offers. We do offer individualised services for people's communication, but we also support broader communication access with disability awareness training options and education programs across the lifespan. An accessible information service where we do prepare easy English documents using that co-design and also consumer testing process, and that supports people to read and understand information that's specific to your context. a suite of e-learning options that can be either embedded into your existing training programs, support your own accessibility and inclusion framework or action plan, and be accessed in a range of different ways. And as mentioned before, Scope also has Keyword Sign Australia as a business unit. So we can develop and provide access to a whole range of keyword signing training and products for anyone with an intellectual disability who accesses your service, who uses this method of communication. So I feel like that's a very whirlwind tour through lots and lots of opportunities. But to finish, it's about thinking holistically about a person's health journey, and that it's not just that moment that they see you in your rooms, but the preparation that goes into it, the interactions that you have, and that bigger picture awareness of the environment and communication access within the community. Thank you so much.
Thank you so much for such excellent presentations, both Leah and Marie. Really, really great to hear from you today. And Marie, thank you so much for sharing your personal story with us today. We can definitely take some lessons from that as we try to encourage more health professionals to be more inclusive, and particularly being respectful in the communication with patients. So thank you both very, very much for your time today. Today has been a really informative session from all of the speakers. So I would like to say a very big thank you to Kathy Basterfield, Leah Dark and Marie Ireland for your contribution today. We do greatly appreciate your involvement, and there's been some really excellent content shared today, including both practical and applicable things that people can take away from today's session. So we are coming to a close. So once again, thank you very much for all the presenters for your work today. And can I ask that attendees please take the time to complete the participant evaluation survey via the QR code on the screen or in the link in the chat. And we've been really, really fortunate to hear from such excellent presenters today. So on behalf of Western Victoria, thank you very much for your participation today.